Assalamu alaikum. Let's make sure that we put this workshop in better perspective in terms of making sure that we come out of here of something practical on what we are going to do in the lab and in the clinic. So that's why if you look at the agenda, there'll be short presentation about the status of the science, status of the field. Then we go into practical aspects of this. Now, I could understand quickly why the pathologists sometimes get confused what they need to do and what type of PD-L1 testing they have to do and so on. And I'm going to make your life easier today. And the most important thing is whenever you are asked to do a test, you just ask your oncologist why he wants the test. If he doesn't know why he is asking the test, don't do it for him. And come and tell him Dr. Jazieh told us that. Do not do it unless he has to do something with it. So you'll be surprised how much people are fishing sometimes, how much they want to do research, and they are doing it in circumvented way and so on. But if somebody come and tell you, look, I have very rare tumor, I have this case report, I want to look at it. So I mean, I'm the one who pushed the envelope as much as you can imagine. But somebody has to know why he is doing the test basically, and not just let's fish and so on. So basically, what we'll be talking now about, quickly I will go through immuno-oncology in general, and then try to zoom on what we expect in the clinic, because the oncologists are standing in front of the patients and they have to make a decision. And you cannot imagine, for example, the struggle we go in when the percentage, for example, is 49% of PD-L1. Why 49, for example? So that's why so we have to make sure that we understand, and that's why we have to talk together. Please, whenever you are having your own meeting, make sure that you have an oncologist sitting with you and talking with you. And the same when the oncologists are talking, because in the end of the day, you are the one who are going to educate the majority of us on how we are going to interpret this. It's way above my head. So the things that, the reports that I'm getting now from Turkey, way above my head. So then we have to make sure that we are talking to each other much more often than we used to do in the past. So there are more than 2,000 studies, more than 500,000 patients participated in clinical trials. We are clearly in a new era. I'm going to talk covering these topics. I'll move on quickly to cover it rather than spending time on reading the headings. We are dealing now with the new mechanism of actions. We are basically enhancing the immune system to take care of the cancer. And this could be good and could be bad, of course. It has other side to it because, you are waking up the immune system, which sometimes it goes, beyond just targeting the tumor and targeting the self. And that's why you have some good effect and bad effects that we have to balance. I'm not going to go through the mechanism. Dr. Walid mentioned it. So the indications, it's endless. Every week we have a new indication. So look at this, and these are all within the last 1 to 2 years, by the way. So every day, and every time I'm opening the internet, I'm expecting to have something about immuno-oncology. So basically, in many of these diseases, we have now many of the cancers, we have different type of immune therapies. And I'll show you the lung cancer. We have multiple, actually, in lung cancer. But for you, that's why, please, as a pathologist, you have to have very simple, clear vision about this one. So you see how many PD-L1 testing, I don't care about all of them. It doesn't mean anything to me except one, CC23. The 223C, whatever, that's C3, whatever, that's the one that goes with Pembro. If you do 1,000 tests of the other, it doesn't mean anything. It's neither FDA-approved, nor I'm going to use it in the clinic. So if you have a kit, if you have using this, if you have the machine, it doesn't mean anything to me in the clinic. So it's very important to know this. So there's something called scientific exercise, good brain mental exercise, but what does it mean in terms of translating into the clinic? That's what's important to all of us. We are all here to help the patient. So look in lung cancer. We have stage 3, durvalumab, marvelous result. Now, in lung cancer, and that's the actually practical use of PD-L1. PD-L1, more than 50%, we can use pembrolizumab single agent as a first line alone. Better than chemotherapy, overall survival, progression-free survival, side effects, everything. So all what I need to know, the 223C or C3 is more than 50 or less than 50. Please don't make it 49 or 48 or something. So that's the issue. So because it has to be a comfortable margin. So I know I make a decision. So I make clear decision. Okay, this is immune therapy patients first line, or no, this is not immune therapy. Now, by the way, there are multiple drugs getting approved, including the Pembro, with chemotherapy, irrespective of the PD-L1, whatever is the PD-L1. But the standard of care now, I need it to be more than 50 to give single agent immunotherapy. Now, so these are the first line. I told you there's chemotherapy now. Atezo and Pembro with chemotherapy likely is going to be used in some of the patients, but still the single agent Pembro has to be PD-L1 more than 50. Now in the second line, I can use two agents irrespective of the PD-L1. Even if the hospital don't do PD-L1, do not worry. Your oncologist still can use other certain agents. However, if you want to use pembrolizumab because of cycling, dosing, because of other things, it has to be also positive in the second line. But in the second line, more than 1%. First line, more than 50%. And that's why we should do PD-L1 is reflex testing. We should do it in all the patients. We start with the molecular because the molecular still have the hierarchy in terms of decision making. And still, so immunotherapy doesn't work well in patients who have driver mutations. So EGFR, ALK, ROS1, all this genetic testing take a precedence over the immune therapy. So we have to make sure it's negative. If you have enough tissue, do the PD-L1 on all, adeno and non-adeno, everything. Because then it helps us decide about even the second line. If I did not use it in the first line, let's say it was 40, 20, then it helped me in making decision about the second line, okay? So if you look at this one, so here how we are making now the decision in terms of the molecular studies. Here, this is stage 3. I'm just showing you in the NCCN. So durvalumab, if you have stage 3B, where you give chemoradiotherapy and the patient has disease control, we give durvalumab as a maintenance. And then the second thing is also, if it was stage 3, got chemoradio with good disease control, we use durvalumab. So that's the first approval in early stage lung cancer. Now, so you look here, this is how we work up lung cancer. So, if it's look at this, please, at least, we have to be on the same page, although I don't push hard for the squamous cell. But basically, for all the non-squamous, we have to do the EGFR, ALK, ROS1, BRAF now. It's in the guideline, we treat BRAF, and then PD-L1 testing. So then in the NCCN modification of guideline, we are saying now we really need to have molecular tumor board in each tertiary hospital. So inshallah, in the next couple of weeks, within the next month, we'll start our oncology precision oncology tumor board. Because we have to, go through these things and see what we are going to do. Then you do PD-L1 testing. By the way, squamous cell cancer, if a patient is non-smoker, and so it's pure squamous and we still can do the target therapy. But again, PD-L1 testing is part of them. So if your oncologist call you and say, please do it on squamous cell carcinoma, do it. But these are the patients who are non-smokers, and you think that they may have a mutation. Much less prevalent, but it's there. Okay, so this is the PD-L1. Look at this. It has to be more than 50%, more or equal 50%, but EGFR, ALK, ROS1, BRAF negative for me to treat with pembrolizumab. Okay? Now the other, so if you look at the second line, I have chemotherapy, then I have Nivo, Pembro, and Atizo. And in Pembro, when you read in this Pembro, they say it has to be more than 1%, as I explained to you. So this is for the second line. Patient selection, patients with autoimmune disease, ulcerative colitis, Crohn's, rheumatoid arthritis, SLE, organ transplant on immune suppressant should not get immune therapy. Efficacy, basically immune therapy beaten chemotherapy in all aspects, not targeted therapy though, beaten immunotherapy, beaten classic chemotherapy in all aspects. Lesser side effect, better response rate, better progression-free survival, and better overall survival. So look at this. This is, for example, for the durvalumab. Look at the curves, how nicely separated. So this is, this is for also Pembro in the first line. Look at the curves. It's unequivocal. The curves are nicely separated, and so on. So this is for, squamous cell carcinoma, second line, curve separated. Non-squamous, curve separated. Pembro in the second line. So I'm just showing you, we don't have to go through the details, but I'm showing you how, almost cut and paste these curves. They're beautiful, really. We did not see these curves for a long time. That's why we are very excited about it. And it's survival, overall survival. So response pattern, now we are seeing relatively the response rate is not as high as target therapy. Sometimes it's equivalent to chemotherapy in terms of the tumor shrinkage. But the good thing is the quality of the disease control is long. The stabilization of disease is long. We are seeing responses in very difficult to treat patients, like in the past, squamous cell, smokers. You may have response after months of therapy. So some patients may respond after a year. So if you did not do, you are because you are a doctor, people will ask you, oh, my tumor, I was immune therapy, my last CAT scan did not show any changes. No, it's good, it's okay. We continue on treatment. So even some patients got one dose of immune therapy, one dose, and have side effect, left back on phase 1 studies, left back to their country, and they have complete remission and cured from their cancer. We have something called flare-up, which is hot tumor and pseudo-progression, because sometimes physician may do biopsy sometimes, and you see much more infiltration of lymphocytes. So you see here the tumor here was before treatment. Look how it got bigger, and then it got good response. So this is called a flare-up or pseudo-progression, because of the trafficking of the lymphocytes and infiltrating of the tumor. So this is, this is 2 years response. Patients 2 years after treatment is in complete remission. I always say also we owe immune therapy the learning of these new plots, new graphs we are seeing. And this is, something very nice. Now you can look at the graph and you can tell a story about it. So you can tell, so if you look at it, the median time to response, which is that it's almost similar to the chemotherapy. These are still responding. This is responding after the last treatment. Look at this. This took few months, took 56 weeks, almost a year to respond. So on. So there's a lot of things. So it tells you about this one. So this is also tells you, about the cases based on PD-L1 and so on. So you see the arrows mean continuing responding. Now we can even plot, this is called spider plot. We can plot the dynamic of response. So the kinetics of response. We can see what happened to the tumor sites. So for example, this patient responded right away and continued to be in CR. This patient took a long time, 12 months, then he responded. Look at this, he was a stable disease, then boom, responded. This patient did not respond right away. This patient, the tumor grew a little bit, then he responded. So you can tell from these stories what happened to each patient tumor size. Side effect, we have less side effect generally, but different side effects. So, as a pathologist, you'll be encountering these. Please now, when you are getting the history of, when you are getting biopsy of a cancer patients, please try to make sure that whether they are getting immunotherapy or not. And, because now you have, we have patients who have ulcerative colitis. Well, he never had ulcerative colitis. The guy was normal all his life, but he's on immune therapy, and now he has symptoms of colitis. So when you are looking at the biopsy, you need to keep this in mind. So they have this itis syndrome: pneumonitis, thyroiditis, nephritis, hepatitis, colitis, and so on. Albeit rare, but it's there, So and so you may be seeing these biopsies. So the itis, the endocrinopathies, generally mild, reversible, manageable. But if you overlooked it, it could be fatal, especially the hepatitis and pneumonitis. Special consideration, I'll try to simplify what is needed, or at least, as an oncologist, what type of help we need from you. In the initial workup, we need still to determine the primary. This is still paramount till now. I know we are dreaming of having just molecular profiling or genetic profiling of the tumor and treat irrespective of the primary. We are coming that way, but for now, we still need to know the primary. Okay, so we cannot go right away to liquid biopsy, for example, and have a target if you don't have primary diagnosed and confirmed. Okay, so remain very important, and the subsequent workup is very important. So we have to have the primary, unequivocally, the subtype of cancer, especially in lung, is also determined. So we do in lung cancer and in other diseases that have targets, next-gen sequencing or specific disease, specific testing, for those who doesn't have more than one target or two targets. So based on the disease, and you help the oncologists, you educate us about this one, interpret the results. Okay, so even, by the way, till yesterday I was reading the Foundation Medicine. I thought approved treatment, and I challenged the guys from Foundation Medicine. I said, this is not approved for this indication. They said, no, it's not approved for this indication. It's approved for this target in other diseases. So you have to make sure that we get educated about this. You educate us about, your reports, and you try even, if you work with your oncologist to make sure that the report is interpreted. And as I tell my teams, here, every time I call you for something, there's something wrong with the system. That means, you did not explain to me enough, or I did not understand you enough, or something. So we need to keep talking till I minimize calling you, except when we are meeting routinely to educate each other. So that's why, you need to make sure that you report in a way that is interpretable, and then the oncologist can make a decision based on it. Because you'll be getting 20, 30 pages. Even difficult for, without having proper even software and so on to do this, is going to be difficult for you to do that. But we need to weed out through this information and not to get drowned with a lot of data. Then we obtain PD-L1 testing, the FDA-approved, that has clinical implication, that I can make a decision based on it. Then treatment, when we are treating the patients, recognize the pseudoprogression. In case you get biopsy from a large tumor and you saw a lot of lymphocytes, inflamed tumor, you know what's going on, so you can explain it in a way that, oh, by the way, this is flare-up, this is pseudoprogression, and so on. Recognize complications, as I said, colitis, pneumonitis, and so on, and be part of the team discussion, so we can all understand the whole picture. You understand what's going on in the clinic, and I understand what's going on in your lab. All the other team members has to be educated. The pulmonary need to know to get adequate tissue biopsy. They need to pay attention to immune-related pneumonitis. Radiologists need to be aware of pseudoprogression. Surgeon asks, can we do surgery on patients on immune therapy? Yes, you can do it next day after the dose. It's okay. There's no risk and they have now a role of oligometastatic disease. You can combine radiation with chemo, with immune therapy. All the other subspecialty need to be aware of this. An oncologist has to be aware of everything. That's, we have to know what you are doing. We have to know what the pathologist, what the pulmonary should know, what the radiologist should know, and so on. So immune therapy in lung cancer and other oncology diseases is here to stay. It's marking a new era in fighting against cancer. And we have to be all together as a team. Thank you.